By the end of this specific video, you should be able to explain the concept of carbohydrate content and list the carbohydrate content of a few foods, and then demonstrate some counting skills, in particular nutrition exercise to help with a diabetic patient. So now I wanted to switch into a discussion about some of the medications and lifestyle modifications that our patients can use in order to control their diabetes. So we're going to go over some common medications first, and it's worth pointing out that the medications are really only for type 2 diabetics, and that typically you'll have a lower chance of success if you've had diabetes for more than 10 years, or if you're currently taking 20 units of insulin daily already. And I think it can be important to communicate with your patients that there's no best pill, and responses to medications can change over time. And so this is something that, and so I just wanted to go through a few of the basic categories, and please forgive me for my pronunciation. It's not always great. So we have acrobose and meticulitol, which both lower blood sugar levels by blocking the breakdown of starches. And this, as a general side effect, can have gas and diarrhea. Other big ones, so like metformin, which is probably the most prescribed diabetic drug, or glucophage, which is its generic counterpart. They both decrease glucose production from the liver, and they can cause diabetes or diarrhea. But this can be improved when you're taking it with food. We then have bile acid sequestrants. So these lower cholesterol and blood sugar. Basically, they lower cholesterol by binding LDLs with bile salts, and that takes it out of circulation. So then the body uses cholesterol to replace the bile salts. And sometimes this can have the side effects of flatulence and constipation. Dopamine 2 agonists to lower blood sugar after meals. The mechanism of action is not incredibly clear. And then we have DPP-4 inhibitors. So these are pretty much any drug that ends in gliptin, and they improve HA1C levels by preventing the breakdown of GLP-1. And this is a product of glucose metabolism. So by preventing its breakdown, it promotes the breakdown of blood sugars. And I think it's important to note that it typically doesn't cause weight gain and can actually include or improve cholesterol as well. And of course, there are more medications to cover, and these are certainly not exhaustive. But next we have the miglitinides. So these stimulate beta cells of the pancreas to release insulin, and so this can help to lower blood sugar levels, and you take it before each meal. It's incredibly important to note that you do not combine this with sulfonylureas, because it can easily result in hypoglycemia, and that can put your patient in the hospital. In addition, we have the SGLT2 inhibitors. So these end in flozin. They act upon the sodium glucose transporter 2, which is found in the nephrons, and this prevents the reabsorption of glucose. So overall, you end up urinating out more glucose. Now, obviously, this can then cause urinary tract and yeast infections because you're now putting a high volume of glucose into the urine and constantly through the urinary tract. Sulfonylureas end in vridazide, and these stimulate beta cells to increase the release of insulin as well. Again, don't combine with the miglitinides. Various side effects alone can include hypoglycemia, weight gain, and gastric upset. Next, and finally, we have the TZDs. So these typically end in zone. They reduce glucose production in the liver and can actually improve insulin response in the muscle and adipose tissue. So this helps to reduce HA1C levels, and generally they have a few side effects, but there's some concern over increased heart failure. So some populations may do better on this than others. So before I was discussing the cost that diabetics often incur in going through different groups of people to compare costs. And then we just covered the standard medications. So I thought it was also important to discuss how you can reduce the cost of those medications. So first one is just a price shop. I recommend using GoodRx, which I've listed in the syllabus, or just looking at local pharmacies. Some larger pharmacies like Walmart have the $4 list, of generic versions of prescription meds that you can purchase. And then in general, use the generic versions. They're just as effective. In addition, ask your provider to provide the largest tablet strength that's reasonable for the patient. And then you can tell the patient to split the pill into the proper dose. Always order in bulk. That will typically drop the price. And then you can always help your patient check for different classes of medications. So we just went through about 9 different classes, some more expensive than others. And so if they can tolerate it or if they would do just as well, you can switch them from one class to another in order to save money. So we've been discussing medication, and a lot of the data has focused on type 2 diabetes, but I also wanted to discuss insulin, which is what type 1 diabetics need in order to control their blood sugar levels. And when you're discussing insulin, typically there's 4 things worth noting. The first one is the onset, so how long does it take the insulin to reach the bloodstream and start to act? The peak time, so the time at which insulin is at its full effect. How long the insulin is then effective is the duration. And then the strength. Strength is represented in units per milliliter, so it's a concentration. And so you might see something like U40, and that's saying that there's 40 units per milliliter. And then U100 would mean there's 100 units per milliliter. So I'm talking about units. Units is defined as the amount of insulin needed to lower blood glucose levels by 50 milligrams per deciliter. So patients may start with 1 unit of insulin per 1 to 2 kilogram of body weight per day. And so this can mean maybe roughly 40 units for a 70 kilogram person. Traditional delivery of insulin is in vial and syringe, but you can also have pen injections, which are typically pre-dosed to make it simpler for the patients to use. And then I just thought it was worth pointing out some costs of insulin. So in 2017, there was nearly $15 billion spent on insulin. And then from 2014 to 2019, the average price of insulin rose 49% per unit. And so this is something that is well known to be occurring in our medical system. In the realms, I provided an article about that's a cost comparison across different medications, including insulins. And then it's also worth noting that recently Walmart has started to provide a generic version of insulin at a cheaper price, and that's hopefully going to reduce the expenditure that patients take on. So we're not going to go through all the different brand names or generic names for insulin. I just wanted to show this graph to demonstrate the different types of insulin. So there's rapid acting, and that can, as you can see, it has a very quick response time, but then declines very quickly. Or then you have something like glargine, which is longer acting. Takes longer to reach full effect, but stays at that effect for up to 24 hours. And so it really can depend upon the patient's lifestyle as to which insulin they use. So if we're going to discuss how to lower the cost of medications for patients, it's also worth discussing how to reduce insulin prices for patients. And mostly you want to follow the similar steps listed on the previous slides. So use GoodRx, order in bulk. You can order in higher strength and then dose appropriately. In addition, on the last slide, I mentioned Walmart's new product. So it's a insulin analog. It's called Relion Novolog, and it's thought to save up to $100 on vials with an average cost of 72.88 cents. And then savings up to $250 for the flex pens or the pre-dosed pens, with an average cost of $85.88. And then finally, patients really should consider lifestyle modifications, diets like the DASH diet and the Mediterranean diet, which are covered in other videos. And you also highly want to recommend that your patients count carbs. Exercise, of course, has great long-term effects of improving insulin sensitivity, so combating type 2 diabetes, and can also improve HbA1c levels up to 1%. And if you recall on the diagnostics, 6.5% is considered diabetic, so a change of 1% can bring them easily into a more controlled area. So I mentioned counting carbs before, and the reason why this is highly recommended is because it can delay complications from diabetes. And you can then match the amount of carbs you're eating to insulin to have better overall control. Generally speaking, there's three types of carbs. You have your sugars, which are your fruits, and then you have dairies and sugary drinks. You have your starches, so wheats, oats, grains, potatoes, beans, peas, all that good stuff. And then in some of your vegetables, you also have fiber, which is indigestible. So it's not really providing any calories, but it does help to provide better control. Now you can tell your patient that one carb serving is 15 grams of carbs, and that there are 4 calories per grams of carb. So overall, you can then tell them to aim to get about half their calories from carbohydrates. On the right here is just a serving of a potato. So if you look and go all the way down to total carbohydrates, has 29 grams of carbs. And so that would put you almost at 2 servings. So even though it's a serving of one potato, it is actually 2 carb servings. As always, thank you for listening. I highly recommend that you view the videos on nutrition counseling and exercise counseling because those are very relevant to the lifestyle modifications for people with diabetes. And then don't forget to look at the other sources provided in the syllabus. Thank you.